Today we're going to talk about the swollen knee. The presentation of the swollen knee is variable. It can occur spontaneously, chronically, or traumatically. The swollen knee causes pain, decreased range of motion, and a feeling of fullness or tightness in the knee. It often comes with a sense of warmth, but is rarely infectious. If the effusion is all around the knee, it's truly a de-effusion. If it's just the anterior, it's more likely to be an inflated bursa. Effusions can be divided into multiple categories depending upon what their etiology is. These will be covered all in detail, but the basic categories are traumatic, osteoarthritic, polyarthritic, infectious, crystalline, tumor, and hematologic. Traumatic effusions are one of the most common types of effusions. They're typically going to happen some active and has a traumatic history recently. Effusions from a fracture typically have blood and fat droplets in the effusion actually be separated out. Meniscal or ligament tear would be an effusion purely with blood without the fat droplets. Patella dislocation can be either, and an OCD or traumatic loose bowel can also be either with or without blood. The osteoarthritic effusion often has a synovial effusion with a little cellular component to it. And it occurs from overuse in a patient with known or unknown osteoarthritis of the knee and may have a previous history of pain and swelling. Infectious effusions tend to have a synovial infusion with a significant white cell component, often greater than 100,000 per field. Staph, strep, gonorrhea, Lyme, and tuberculosis are the most common causes of an infectious effusion. A crystalline effusion also has a high synovial and white cell count, with over 100,000 often in a crystalline effusion. Common causes are gout, pseudo-gout, and other inflammatory arthropathies. Polyarthritis can have a synovial effusion with a smaller amount of white cells. These are commonly things such as Reiter's syndrome, juvenile rheumatoid arthritis, rheumatoid arthritis, and others. Tumors can also cause effusions in and around joints. There are many types of tumors, both malignant and benign. Too many to cover in today's topic. However, it is important to try to rule out tumor before aspirating a joint, and therefore x-rays are crucial. Non-traumatic hematologic effusions come from two major sources. One is iatrogenic from anticoagulation, and the second would be systemic from diseases such as hemophilia. The diagnostic approach to an acute effusion can be challenging. The first question that should be asked is whether or not there is trauma. In the event of trauma, you should take x-rays and find out if they're normal. If so, one should consider ligament tear, meniscus, or patella dislocation that's reduced. Abnormal x-rays include fractures or fractures of osteophytes and arthritis. Also, unreduced patella fractures or dislocations. In the event that there's no trauma, whether or not multiple joints are involved or if it's a single joint, check x-rays and see if there's signs of infection. If there is, the common infection sources should be considered. No infection, crystalline, systemic, or Lyme disease should be considered. With abnormal x-rays in multiple joints, arthritis, rheumatoid, crystalline disease, and others should be considered. In a single joint, again, check the x-ray. If there's signs of infection, in a normal x-ray, look for acute septic arthritis, Lyme disease, with no signs of infection, crystalline, rheumatoid, or other systemic causes. Abnormal x-rays can be tumor, arthritis, rheumatoid arthritis, or other arthropathies. When and how to image the acute knee is always a concern. Almost all acute knee presentations should get a plain x-ray to look for arthritis, fracture, dislocation, tumor, AVN. Standard plain x-rays are weight-bearing AP, 45 to be a PA, a lateral and emergent. Chronic knee conditions do not need new images unless there's been a change. MRI is indicated for concerns of ligament tears, patella dislocations, knee dislocations, mechanical locking, concern for tendon rupture, fracture not seen in x-ray. 3T MRI is far superior to 1.5 in terms of picture quality. It's more open, therefore less claustrophobic. Closed is better than open MRI. MRI is not indicated in many conditions as listed above. Diagnostic labs can be useful in the acute or chronic non-traumatic effusion without known source. The standard panel for this includes CBC with differential, ESR-CRP, Lyme titer, rheumatoid, HLA-B27, and ANA, also uric acid. Knowing when to aspirate a knee is important, and a total knee you should almost never aspirate it. You can be sent to the joint surgeon. In trauma, the aspiration can be done for pain relief, if not anticoagulating. In non-traumatic, for diagnostic purposes, aspiration can be very helpful. It should be sent for a cell count, a gram stain, culture, and microscopic analysis for crystals. There's definite diagnostic value to the white blood cell count in an aspirate. Anything more than 5,000 in a total knee is an affected knee. 0 to 50,000 in a native knee can be anything. 50 to 100,000 is more likely inflammatory. Greater than 100,000 and certainly greater than 150,000 can be infectious. It's also important to know when not to aspirate. In a total knee, unless it's a life-threatening or limb-threatening emergency, you should not aspirate. If the patient is anticoagulated, there's concerning findings on x-rays such as tumor, mild pain or dysfunction, then the risks outweigh the benefits, and in a hemophiliac patient with an abnormal cell count. Here the provider is finding the superlateral portal just to the superior aspect and lateral aspect of the superior pole of the patella. There's usually a soft spot that can easily be palpated. Next, the skin is prepped with antiseptic, either chlorhexidine or betadine most commonly. A 22 or 25 gauge needle is then used to infuse a wheel of local anesthetic. A large needle is then placed into the knee joint. I prefer a 16 or 18 gauge needle so thick fluid can easily be aspirated, and the remainder of the fluid can be milked over towards the needle to make sure you get the complete aspiration. In patients where an aspiration and injection are done at the same time, the syringe can then be removed, and the syringe containing the injectable medicine can then be placed on the same needle in a sterile fashion and injected into the needle. Finally, the needle is removed, pressure and a bandage is placed.